Good evening. Welcome to Chicago again. Think about the case that Bruce presented early on. It was a patient that required failed conventional therapies, moved on to biologic therapies, treated initially successful with an anti-TNF, and then loses response to the anti-TNF, even though there's the presence of the infliximab within the bloodstream and no insignificant antibodies to it. This is a patient we see all the time, and I just point out that inflammatory bowel disease is complicated. A patient responds initially, then loses response, even though they've got the active drug within them. And that's because the immune system is complicated in and of itself, and there is a great deal of redundancy within the immune system. There will be a little bit of the redundancy in our discussions because we're talking about similar mechanisms. Now, just to emphasize a couple other things between small molecules and large molecules. And there's a representation of aspirin at the bottom and a monoclonal antibody at the top. Now, Bruce described many of the attributes of these, but one additional attribute that I want to point out is that the protein structure, the amino acid backbone of monoclonal antibodies, is very easy to recapitulate, to make an identical amino acid backbone. But what then happens, what allows these big protein structures to develop their functional characteristics is how they bend and they fold. And that's related to the post-translational, I used to say the way you get a gastroenterologist to fall asleep is to say that there's a genetic polymorphism in the thiopurine methyltransferase enzyme system. Now I say the way to get a gastroenterologist to fall asleep is to talk about post-translational carboxylation, which are all the sugar moieties that surround that protein structure and give it its tertiary and quaternary structure and hence function. And Bruce mentioned that there are a lot of different variables that may impact on that. And those variables include the pH, the temperature of the bath, the different sugar concentrations that it's bathing in once it gets into a vial, whether you actually shake up the vial. So there are many different factors that can impact on that carboxylation. Now, also, let me put that concept into perspective. These carboxylation groups include fucosal molecules, the fucosylation, the adding of a fucose molecule. Well, in our day-to-day practice, we actually use this all the time. It's called hemoglobin A1C, which has an added carboxyl group to it in individuals who have high sugar concentrations in their blood. And that's how we actually monitor diabetes, obviously. So the different concentrations can impact on the structure and hence can impact on the function of these larger molecules. Now, we'll get into a few other slides that just actually also recapitulate what Bruce has already said and the different points within the immune inflammatory cascade that seem to be overexpressed or overproduced in the setting of inflammatory bowel disease that become targets not only for our small molecules, but also for large biologic molecules, which, as Bruce has already described, are much more specific and focused and targeted to specific ingredients or specific proteins or receptors along the way. There are different phases of inflammation in IBD, and Bruce alluded to this also, that in the initiation, there are factors that initiate the disease, there are factors that perpetuate and amplify the inflammation, and then in order to heal, there are counter-regulatory proteins, such as TGF-beta, that come in and help the bowel actually function. But these, in and of themselves, are extremely complicated. You can't look at them in isolation. There are what are considered to be networks of different cells and cytokines that we're still elucidating and still don't know all the aspects. And every year we hear about another different cell functional type. Most recently, the Th17 cells that are going to be very informative, because when you inhibit Th17 in psoriasis patients, you get great clearing of the psoriasis. But when you inhibit Th17 in IBD patients, the IBD actually gets worse. So it's one of the few targets that are effective in our companion immune-mediated inflammatory diseases, rheumatoid arthritis, and in psoriasis, that actually have opposite effects in the setting of ulcerative colitis and Crohn's disease. Under normal situations, our gut is in a state of controlled inflammation. Indeed, when we get biopsies back from our pathologists, the description of chronic inflammation is often misinterpreted as being abnormal. The chronic inflammation within the gut is actually a normal state, and we should be seeing responses from the pathologist saying without diagnostic abnormality. However, when we have acute inflammation manifest by an increased numbers of neutrophils and other cells infiltrating into the gut, is when we get the activity of inflammatory bowel disease, and then it has to downregulate and reconstitute the epithelial lining itself, which is the repair mode. Now, Bruce also already talked about leukocyte trafficking, which we've recognized now is very important in the setting of inflammatory bowel disease. And indeed, we have examples of that effectiveness going back now several years to natalizumab, or what was is currently marketed as Tysabri. We demonstrated that Tysabri was effective in Crohn's disease, a little bit like we're going to learn from vedolizumab. With natalizumab, it took a longer time for patients to respond by inhibiting the cells from going into the tissue, but not affecting how they move out of the tissue. There are a number of different receptors around the body that Bruce already mentioned. VCAM, or the vascular cell adhesion molecule, is ubiquitous. It's in all of the endothelium around the body. VCAM is inhibited by, or is stimulated, or let me say it differently, links to the alpha-4 beta-1 integrin. So the integrin are the receptors on the leukocytes, and the addressins, where to get off in the bloodstream, are present on the endothelial cells. And in different parts of the body, there are different receptors in different locations. VCAM is ubiquitous, including the brain. If you inhibit this with natalizumab that blocks alpha-4, hence alpha-4 beta-1 as well, you prevent lymphocytes from getting into the brain. They can't survey the brain, and if there's a virus there, it can reactivate and lead to the JC virus activation and progressive multifocal leukoencephalopathy. Within the gut, there is a specific addressin called MADCAM, the mucosal addressin. The mucosal addressin links specifically to alpha-4 beta-7 receptors or integrins on the leukocytes. Vedolizumab has been available now for the past several years and blocks the alpha-4 beta-7, and there are a number of other drugs that are also under development that will also block the alpha-4 beta-7. Once you see this concept, you can think about different ways of blocking the different addressins or the different integrins. Excuse me. So integrins are the receptors on the leukocytes, and the addressins, again, on the endothelial cell. One option would be to block beta-7 alone, which would be limited the impact on MADCAM and also be gut-specific. And this is a drug that is currently being developed, and that's etrolizumab, and we'll show you a little bit of data. Personally, I don't like to show a lot of phase 2 data to these audiences because I don't think it really means much. It means that we're going to move on to phase 3 where we'll see the absolute results. So I'd rather show you this more pictorially than with data slides. And then finally, the other option is to develop a monoclonal antibody against MAdCAM itself. And this is also under development with a drug called PF whatever, whatever, whatever. There is another anti-alpha 4 beta 7 that has now been labeled abrilimab. Apologize. So these are all very difficult and new names for all of us to understand until the generics become a more complicated trade name. So MAdCAM sits on the mucosa. It can be blocked directly or via blocking the integrins on the white blood cells. VCAM is everywhere within the body. Now, what's interesting about etrolizumab, which blocks the beta 7, is that beta 7 is also important for egress of the cells out of the tissue. All of the other receptors that block the cells from getting into the tissue block the intake into the mucosa. And we've seen now with natalizumab and with vedolizumab effects in inflammatory bowel disease. When you block beta 7, it has another potential mechanism of action, which is actually to allow the cells to get out of the gut faster. So it blocks them coming in and also accelerates their removal from the mucosa. And it will be interesting to see the comparative effectiveness of etrolizumab compared to the anti-integrins that only block the movement of cells from the bloodstream into the tissue. So there have been recent Cochrane analyses of the limited phase 2 data for both and the phase 3 data for vedolizumab and phase 2 data for etrolizumab and the anti-MAdCAM. And you can see in these preliminary studies for the drugs under development, we're seeing potential benefits that are now being taken into phase 3 studies where we'll see how these drugs actually work when we get into the IBD populations. Now, moving from cell adhesion and the lymphocyte trafficking, we're already familiar with monoclonal antibodies that are targeting cytokines. And obviously, the anti-TNFs have been the most predominant. We have a handful of those, and I'll even discuss some of the biosimilars a little bit later. But the T-cell cytokines are also complicated. They have their own and varied networks, and they impact on each other. So it's difficult to predict in advance how inhibiting one cytokine is actually going to function downstream. And if you remember a number of years back, there was great concern or thought that infliximab or the anti-TNF agents, which were shown to be effective in Crohn's disease, were not likely going to be effective in ulcerative colitis. Yet, when we put it into those patient populations, we were found that we were actually wrong and that TNF is a predominant player not only in Crohn's disease, but ulcerative colitis as well. So with all of the different cytokines that are upregulated within these diseases, there are a number of options and a number of potential targets that have been looked at and will continue to be looked at either alone, and it's challenging enough to examine these one by one, but putting them into combinations is actually going to be even more complicated and more challenging. Thus far, the second target for biologic therapy in inflammatory bowel disease has been the interleukin-12 and interleukin-23 receptors that are blocked by a similar P4, or that are activated by a similar P40 subunit. And this P40 subunit activates not only IL-12 but also IL-23. There is a second subunit, P19, that is important for the activation of IL-23. Ustekinumab, that you're familiar with, blocks P40. So it blocks not only IL-23, but also IL-12. It's been effective, as you well know, and has been recently approved, and I'll show you data in a moment, in the setting of Crohn's disease. And ustekinumab is now undergoing phase 3 trials in ulcerative colitis to see if it will be effective. Now, thus far, ustekinumab, the blocking IL-12 and 23, has been effective in psoriasis, and there have been literally over 100,000 patients with psoriasis treated with ustekinumab, which seems to have a very favorable side effect profile. And I'll show you the data in Crohn's disease regarding this in a minute. But under development are a number of monoclonal antibodies that specifically block the P19 subunit and are specific for interleukin 23 and not interleukin 12. There is some rationale for the specificity of IL-23 in that, at least in some animal models, blocking IL-12 may lead to some additional side effects and infectious complications. But that has not yet been borne out, at least with ustekinumab. So with ustekinumab, we've seen benefits in both an anti-TNF exposed population and an anti-TNF naive population. What we've learned from virtually all of these antibodies is that by the time you get to a second and third biologic, you are taking an overall hit in efficacy. And as you can see, although both in anti-TNF exposed and anti-TNF naive patients, while there were differences with placebo, the absolute response rate is different, and is actually greater in the anti-TNF naive patients. And we've seen that both in induction, as I showed you, and also in maintenance therapy. It's effective in both populations, but the overall response rate is going to be greater as a first biologic than it would be as a second or third biologic. Overall, ustekinumab has been safe in the Crohn's disease population. The safety has been replicated from psoriasis, even though we're giving significantly higher doses. In the Crohn's population, there were no serious opportunistic infections attributed to ustekinumab. There was one case of primary tuberculosis, but cancers have not yet been seen. Therefore, there is now essentially a race to develop multiple or to develop new P19 monoclonal antibodies that will block interleukin 23. And these include risankizumab, risankizumab, gesalukizumab, and some that mercifully just have numbers thus far. We've seen some preliminary data just published over the past several weeks, actually, in The Lancet with risankizumab that looks very promising as a potent agent in the setting of Crohn's disease. And Bruce has already described the results of brazikumab, which is another anti-P19 IL-23 inhibitor that also has had improvement in Crohn's disease. And Corey's going to talk a little bit more about how we might actually get more selective and actually have some potential markers or biomarkers of effectiveness in this. Now, there is a little bit of hesitancy because interleukin 23 is important as far as may have some role as far as tumorigenesis and potentially metastases. Thus far, we have not seen a signal for malignancies, but theoretically, there are some potential reasons why there may be an impact. And then lastly, I want to talk about the biosimilars. Biosimilars are approved now for infliximab. We have two that are currently, one is on the market, one will be on the market shortly within the year, and then a biosimilar for adalimumab that is going to be delayed for several years. It's been approved for therapy in all indications, but because of patent life, it's not going to be marketed for a while. We have seen meta-analyses now. There have been a lot of data for the biosimilars, particularly the CTP-13, which is now marketed by Pfizer through Hospira and also in partnership with Celltrion. It has had comparable effects, similar effects to infliximab in a variety of different trials across numerous indications, and there seem to be no different safety signals with this drug compared to infliximab. In a large study called the Norswitch study in Europe, in Norway, the government forced all individuals to participate in a trial where patients who were on infliximab were either randomized to continue with the CTP-13 or continue on infliximab. And in the inflammatory bowel disease population, it met the criteria for no significant difference in either ulcerative colitis or Crohn's disease. There are a variety of new presentations at DDW regarding these. Although we have a lot of angst in the United States, if you go over to Europe, where these have been available now for the past 2 years, they are essentially part of routine practice, and the majority of countries are forcing more and more patients into the biosimilars because of the significant cost savings. There are a couple of other biologic agents that are being represented here, and I just point out 2 of the presentations that are going to be later in this year, and one might call the allogenic adipose cells that are being looked at in fistula, perianal fistula in Crohn's disease, a form of a biologic, and even the microbial transplants might be considered biologic therapy. But I want to conclude with where we are and where we're going. Our current need, in my mind, is not a 15th drug for moderate to severe Crohn's disease or ulcerative colitis. What we're missing are drugs that prevent the evolution to moderate to severe disease. And we need drugs used earlier in the disease. We need these drugs to work better. Hence, we're all looking, or many of us are looking, at therapeutic drug monitoring. Corey's going to emphasize the need for biomarkers as we personalize therapy. Cost effectiveness is being modified now by the introduction of biosimilars, but we need improved developmental pathways to rapidly get these drugs in through patients. Unfortunately, my near-term expectations are not so good. What we're seeing are drugs added for late disease, and we saw some data of 16% remission rates in ulcerative colitis. Yes, it was better than placebo, but we overall can do better than that. We see marginal improvements in efficacy with these new agents, but we need game changers. Perhaps Mongersen will be one, but we certainly need other game changers in the future. Otherwise, we're going to continue with this incremental process.